Hi, welcome back to another video. My name is Andrea, and the topic of this week belongs to cultural competence and sensitivity in migrant healthcare. So, the main points of the readings, we have three. There are three. And the core idea across the text is that the healthcare must adapt to cultural diversity to reduce health disparities and improve outcomes. So the authors emphasize that cultural competence is not only about having factual knowledge of different groups, but also about respecting patients' values, beliefs, and lived experiences. So Thomas and 2016 highlights how migrants face barriers to healthcare, not only legal or structural, but also cultural and communicational. So she stresses that equity requires different care, not only size fits all, and calls for culturally competent systems. So Tucker at 2015 focused on patient-centered, culturally sensitive healthcare, and where patients themselves define what respectful and culturally care means for they. And they show how the approach builds trust, improves adherence, and directly influences outcomes. And the last one, the Office of Minority Health Report in 2002 provides the policy perspective introducing the CLAS standards, which frame cultural competence as a systematic responsibility through care, language access, and to organizational support. So together, the main message is clear. Health systems must shift from viewing culture as an obstacle to embracing it as a foundation for equity and quality in care. So the emphasis is here because without cultural competence, even if bad treatment cannot reach their full impact. So was anything unclear or confusing? Absolutely. One challenge I noticed is the terminology overlap between cultural competence, cultural sensitivity, and patient-centered care, because different authors use them in slightly different ways, which could cause confusion. For example, Tucker explained that cultural competence is provided focused, while cultural sensitivity emphasized the patient's perception. At first, it was difficult to reconcile these terms, but reflecting on them, I realized the overlap is natural because they represent different perspectives of the same issue. So this gap suggests the need for a unified framework that helps future professionals like me apply these concepts consistently. And the next question is what was new to me and changed my perspective? Well, what struck me the most was the idea that equity requires different care. Before reading, I thought fitness meant treating anyone the same, but Thomas explains that standardization can unintentionally everyone the same and exclude vulnerable groups, cause limited equal care is not always equitable care, changing my perception of fairness in medicine. I was also surprised to learn how much organizational culture matters, because the OMH report in 2002 shows the policies and interpreter services and staff training can be just as important as the doctor-patient encounter. So this broadened my view of medicine, because it is not only about individual practice but also about systematic structure that they support or limit patient well-being. And the other part of this is there something that I would like to explore further or deeper? And yes, I would like to explore more deeply the concept of cultural humility. Yeah, that's a word, humility. I see very reasons suggest moving beyond and competence as a checklist, like boop boop boop. Toward humility is an ongoing process of self-reflection. So I found this compelling because it acknowledges that I, as a future doctor, and in my career, in my preparation, will never fully master another culture, but I can always learn, listen, and adapt to others. Understanding how to integrate cultural humility into daily clinical practice is something I would like to study more. Because I will be a doctor, but not only for specific people. Maybe someday I will stay in a place that people need my services, and I need to learn this because I am not always a student or be in the same place. And everyone agree with that. And can I give one personal or professional example? Because this is the next question related to the readings. And in my own life, I have seen how language barriers can affect care. Like, don't you have idea, guys, how this is difficult for me? Maybe I learned English, I studied in my past, but to talk and feel comfortable with that is something difficult. Sometimes it's scary because I'm not sure if if my pronunciation is the best one, or sometimes I can't find the right words for to say or for express something that I want to tell you. But I'm trying. So a close relative who speaks only Spanish once went to a clinic where no interpreter was available. She felt rushed and misunderstood, right? And later did not follow the treatment correctly. So reading about the CLAS standards and the importance of language access and helped me realize that the experience wasn't just a personal problem but part of larger systematic issue. So this connection made the readings feel very real and urgent. So a conclusion of all of these, reflecting on these readings, I realized that the cultural competence is not optional. It is essential for good medicine in today's world. Migrants, minorities, and low-income groups face unique barriers that cannot be solved by medical knowledge alone. As a future doctor, I must see culture not as a barrier, but I would like to see like a guide to delivering care that is respectful, equitable, and truly healing. So the biggest lesson is listening to patients, to their stories, beliefs, and needs before everything is just as important as prescribing treatments like a medicine. So medicine is not only about curing disease, it is about building trust across differences. And I would would like to finish with this. And thank you for seeing this, for watch and listen, and maybe could be a reflection for you too. So see you guys next week.